Welcome to Auth the Cuff, EviCore's podcast where we'll be discussing issues impacting the healthcare industry. I'm Liz Avila, Vice President of Client Experience, and joining me today is...
Julius Torelli, Chief of Cardiovascular Services for EviCore.
Can you say the name of the podcast?
I don't think so. Do I have to say it 3 times really fast?
Yes.
Auth the Cuff. Auth the Cuff, off the cuff.
Off. So we're going to be talking about issues impacting the healthcare system. So from the patient perspective, provider, health plan perspective, what's going on out there in the healthcare world?
A lot of perspectives.
It's a lot to cover. It's a good thing we've got a lot of hosts. So I was on site with a client recently, and they have our radiology program. They find a lot of value in what we do. They are particularly concerned about overutilization and how that impacts radiation exposure with their patients. And so we were having a good discussion about the program and, tests that we find inappropriate, cost savings that come as a result of that. And then they sort of brought up the elephant in the room, and that is that prior authorization is tough. It's tough on their providers, it's burdensome, and does EviCore realize that? And, the answer was a resounding yes. Yeah. We get it, we hear you. And we've made some investments as an organization to get better with prior auth.
Prior authorization is a challenge, there's no question, right? Administratively, it is a burden. That's the tough part. But I think there's a lot of things that offices can do to make it easier. Mm-hmm. And I think one of the reasons we have a provider engagement team, for instance, right, is going out with the providers, and we really push for that to help them with, how do you start a case? What's the most efficient way? How do you access the web portal? Where do you find the guidelines? Where do you find the quick reference guides so that the information that you need to start the case, to make sure, because what's the most challenging thing for us? It's getting the wrong information, then we can't make a decision, right? Mm-hmm. Yeah. So what did you end up? How did that end up going? What did you end up telling them?
We pointed towards Boston, and we've made some investments as an organization to get better with prior auth. One of them is an investment around our provider experience department. One of them is investment in our technology and how we actually expect cases to flow through our system and making it easier for providers. But we absolutely understand that it can be tough. It can be tough out there for a provider office.
Yeah, I think that was a critical point in our history for EviCore a couple years ago, when we sort of publicly acknowledged that prior authorization is administratively burdensome. The way it's done today, it's challenging, it's costly to an office, and that we're doing something about it. So we're making huge investments in our IntelliPath program, in our electronic prior authorization program. That basically is going to remove the need for having a person at the physician's office there to start a case, to send in all of the information. So there won't be any more faxing of clinical notes in. There won't be a person who has to put in all the demographics and all the stuff to start the case. That will all come in when the physician orders the test right at his electronic medical record. That will come in, and its ultimate stage, the artificial intelligence and machine learning and natural language processing and stuff will actually read the clinical notes and be able to assess, is this an appropriate request or not? And if it's appropriate, go ahead and make the approval and generate the authorization number right then and there. It doesn't even require a review. Now, if it's not, all the information isn't there, or it's not cut and dry, that it's not black and white, there's some judgment there, then it does have to go through a review, which goes first to a nurse, then to a physician to decide if it's an appropriate request or not. But again, that acknowledgement, I think, was critically important, because until we acknowledged that, we really couldn't say that we were doing anything about it.
Mm-hmm. Yeah, I agree. And I think something important that you said is really look at what's appropriate versus inappropriate. And we get so hung up on denials. Mm. That's our value proposition. That's what the providers get upset about. And that's what the patients get really confused about. Yeah. Right? And so if we really are focusing on something is inappropriate for you, I wouldn't want imaging that isn't right for me in that moment. So I think that, it's like a three-pronged issue: the health plan perception, the provider perception, and patient understanding. And they're all interconnected, and how it comes back to EviCore.
That's another big deal. So I think that was a big push that we made several years ago, was to get rid of that term denying the case, even though it's kind of embedded in the industry, unfortunately.
Yeah.
However, it's perceived as you're denying care, and that's the one thing that I think, again, when we go out, there is nothing here that's done in any way, shape, or form denying care in any way. We know that there are inappropriate requests out there, a certain amount, and we just basically have to sort through to find those inappropriate requests. And like you said, no one wants to have something that's inappropriate.
Right.
So it's really about making sure the patient gets everything he needs, not less than he needs, but not more than he needs either, right? So you want to make sure the first test that's done is the right test. So a lot of times we'll have requests that comes in, especially with head scanning. They'll order a CT of the head instead of an MRI in a patient that needs further evaluation. And the CT is not appropriate. It's not going to give you an answer. And so it gets denied. It comes to peer-to-peer. The doctor's upset because he says, this patient's having neurologic symptoms. He's having these worsening headaches. How can you deny this? Whatever. I said, well, we agree with all that you're saying, except the CT is not going to give you the answer. An MRI is what you need. And they'll say, well, the MRI is more expensive. We thought we would order the less expensive test because it would be easier to get approved. And we're like, well, that's,
But then you're going to have to get the MRI at the end of the day, so you're doing both tests.
Right, so now you did a less expensive test that was unnecessary, so you spent that money.
Right.
And so, those are the misperceptions that are out there. It's like, just do the right thing.
Right.
But the other challenge is a lot of the times the right thing is difficult for physicians to know, right? So for many reasons, education, there's so many new tests that are being developed all the time, new indications for tests and things like that. And it's hard to keep up with that stuff. I'm a cardiologist, and I have trouble keeping up just with cardiology.
Right.
Can you imagine a primary care physician who's trying to keep up with everything? It's a real challenge. So that's part of it. The other part of it is, the reality is that in medicine today, we're stuck, especially primary care, but all physicians, being more efficient, right?
Yeah.
Seeing more patients in less time, which means it's going to be challenging to get the information that you need. You're trying to move on, and believe it or not, sometimes it's easier just to order a test, right? And say person's got headaches, you think it's migraines, he's not having any neurologic symptoms, doesn't really need a study, but it's easier to get out of the room by saying, we're going to do an MRI just to make sure everything's okay, and the patient's sort of relieved, and you can sort of scurry out, as opposed to saying, wow, this headache seems to be getting worse. What's going on in your life? Because that's
takes a lot longer.
Yeah, that's a scary question, right? Because they may start talking and you never get out of the room, right? Right. But that's the reality of medicine today, right? Those are the things that have happened, and so I get it.
Yeah.